that we should be aware is a commercial aspect of the science, and too many advertisement that we have of the AI. And somehow we have a real good data and trends topics into it, include the lifestyle, mobility, and different factors that can be very helpful in terms of the diagnosis. Also, I think that everybody about the different kind of deal makers out of the world, they're all together.
Hello and good afternoon to everyone present over here. Welcome to MedNews Week conference, where our goal is to bring you the most cutting-edge information from medicine's global leaders. I am Madhuri Balasubramanian, and I will be your host for today. Before we begin, I want to first acknowledge the great team that helps to make these events a reality. Our founders are two internationally recognized researchers, Dr. Jan Leifman and Dr. Chandler Park, who is also the president of Kentucky ASCO. Our chairs include Drs. Park, Leifman, and Pratyusha Ganta. Our organizing committee is comprised of Alexandra Van der Kijf and Dr. Yavuz Sile. Our managers include William Wilkerson, Muskan Joshi, Pallavi Pai, and Gayatri Menon. Our educational committee includes Sean Jacobis, Amarel Shamon, Shubha Pawar, Janvi Shah, Asta Nayak, Harshal Choria, and myself. The moderator for today's event is Gayatri Menon. Now, to introduce our keynote speaker, Dr. Aasma Shaukat. Dr. Shaukat is an internationally recognized gastroenterologist with a passion for patient care, research, education, and public health. She is a global leader in translational research on colorectal cancer screening and its indications, long-term outcomes, and prevention. She did her fellowship in gastroenterology at Emory University School of Medicine. She is the Robert M. and Mary H. Glickman Professor of Gastroenterology and Medicine, Director of the GI Outcomes Research at the NYU Langone Health, Professor, Department of Population Health at NYU Grossman School of Medicine. Dr. Shaukat is a part of prestigious organizations such as the U.S. Multi-Society Task Force on Colorectal Cancer, American Society for Gastrointestinal Endoscopy Quality and Safety Committee, American Gastroenterological Association Clinical Updates Committee. She is a recipient of the ACG Governor Award for Excellence in Clinical Research. She has mentored over 100 successful trainees in all stages and is an accomplished lecturer who has delivered over 100 presentations globally. She was formerly a program director at the Minneapolis VA healthcare system. Her area of research focuses on screening, long-term outcomes for colorectal cancer, quality indicators for colonoscopy as well. She has authored over 100 peer-reviewed publications, abstracts, and book chapters in renowned journals such as the American Journal of Gastroenterology, the New England Journal of Medicine. She obtained a VA Merit Award to study long-term benefits of CRC screening and published the findings in the first authored paper in the New England Journal of Medicine in September 2013. She holds multiple federal merit awards to study quality indicators for colonoscopy, such as adenoma detection. I am truly glad to have an amazing conference here with her today. With that, it is my pleasure to welcome Dr. Shaukat. The floor is yours now.
Thank you so much for that kind introduction, and thank you so much for the organizers and the wonderful committee for putting this together. Indeed, what a great effort. So thank you so much for that very detailed and long introduction. Hello, I'm excited to be here and talk to you about a very important topic and provide you some updates in colorectal cancer screening. So we'll get started. All right, so in the next, my goal is that in the next 35 to 40 minutes, I'll review with you some recent trends in colon cancer incidence, particularly in the US, and provide you some updates on the new colon cancer screening guidelines. We can discuss the yield of neoplasia and adenoma detection in this younger age group, 45 to 49, which is of new interest. And I'll leave you with some summary take-home points. So let's get started. I'm going to take you back to 2016, and that's where the story begins. So what did we know in 2016, which, mind you, wasn't very far back? We were screening individuals between ages 50 to 75 for colorectal cancer. These were the US Preventive Services Task Force guidelines. And in terms of the modality for screening, there was no one preferred screening test, but the guideline recommended 7 different tests in 8 different strategies. And because of lack of comparative effectiveness studies, pretty much said one or more of these should be offered. These included coact FOBT, fecal immunochemical testing, or FIT, the FIT DNA test, flexible sigmoidoscopy, a combination of flexible sigmoidoscopy and FIT, colonoscopy, CT colonography, or the septin9 DNA blood test. So this created a lot of confusion amongst provider, healthcare systems, and patients about how they should go about screening, but we were pretty much consistent on screening at ages 50 and older. So then in 2018, the American Cancer Society updated its colon cancer screening guidelines, and for the first time gave a qualified recommendation to lower the screening age to begin at 45. The reason for this was this rising incidence in colon and rectal cancers in individuals younger than 50. And the guideline was informed by modeling studies using 2 of the 3 CISNET models, the MISCAN and SIMCRC, which model the effect of screening starting at age 45 versus 50, using different modalities, and look at life years gained to understand which strategy might be better. And these are some of the data that were quoted in the guideline and were emerging. So on the bottom of this graph, you see colon cancer incidence in men and women in the US over time. And you can see there's a nice downward trend for both men and women in terms of incidence of colorectal cancer, particularly over the last 15 years or so, thought largely due to the effect of colon cancer screening. However, if you look at the top part of this graph, it's colon cancer incidence in younger individuals between the ages of 20 to 49. And there, for both men and women, you see those curves have been relatively flat over time. And in the last 10 years or so, there seems to be an uptick or upward trend in rising incidence. And it's truly this increasing incidence which was the basis for a lot of this alarm and newer recommendations. Now, looking at colon cancer incidence in the US by 5-year increments of age, the one thing you notice in this graph is incidence of colorectal cancer is very much age dependent. Age is the biggest risk factor for colorectal cancer. And looking at this graph, where would you draw the line to initiate colon cancer screening? Largely, studies have demonstrated that when a population's rate is anywhere 30 per 100,000 or higher, screening is both effective and cost effective. And you see that inflection point now at ages 45 to 49. So that's perhaps one of the strongest epidemiologic trends and arguments for initiating screening at age 45. The other interesting finding is that there's a really large bump of incidence of colorectal cancer right at age 50. And clearly, there's nothing magical about 50, except these are probably cancers that were starting to develop, say, between 45 and 49, and were suddenly diagnosed at 50. So that begs the question that if we were to start screening at an earlier age, could we detect these cancers a little bit earlier, perhaps at the precancerous stage, and kind of curb this big rise or incidence right at age 50? Along with that, there's other supporting data. So on the left side of this graph, what you see is the annual percentage change over time for colorectal cancer incidence by decade of age. And you can see that for ages 50 and older, there has been a negative annual percentage change, meaning the incidence has declined over time. However, for ages younger than 50, there's actually a positive annual percentage change, which implies that the incidence of cancer has gone up over time for this age group. And a lot of that increase is in non-Hispanic whites, also American Indians, Alaskan Natives, more than other race and ethnicities. The right side of this graph demonstrates what's known as the birth cohort effect. So this compares everybody born after 1960 to people born in 1940s and onwards. And you can see individuals born, particularly say in the 1970s and later, carry a lifetime increased risk of colorectal cancer compared to cohorts born in 1940. So this isn't a certain time period or years that are affected, but it's truly that entire cohort carries a lifetime increased burden. So these were some of the compelling data that helped inform the guidelines. One might ask a question that perhaps we're detecting more colon cancer at younger ages in the US because we're just doing more colonoscopy. It's more readily available. So maybe for other indications, abdominal pain, diarrhea, we're just having a lower threshold and performing more colonoscopy and picking up cancers that we would have also otherwise had we waited until age 50. Well, this study seems to suggest otherwise. So this is, again, incidence of colorectal cancer by disease stage at diagnosis over calendar years. And you can see there's been an upward trend or increase in colon cancer incidence. And that increase is in all stages of disease, not just local, where one could argue that these would be cancers which would be indolent and still present at age 50, but also an increase in regional and distant spread cancers, suggesting that really we need to be screening them even earlier than we are right now to catch them at earlier stages. So in spring of 2021, we led the ACG clinical guidelines on colorectal cancer. And based on this and other evidence that's summarized in this guideline, we recommended lowering the screening age to 45 to mitigate this rising incidence of advanced adenomas, colon cancer, and eventually mortality from colorectal cancer. And then the US Preventive Services Task Force also updated its recommendation in the fall of 2021 and recommends screening average risk men and women starting at age 45 and gave it a grade B recommendation, which means there's moderate certainty that there's at least a moderate net benefit. The recommended strategies are still several, and they include high sensitivity coac FOBT, or a fecal immunochemical test done every year, a stool DNA FIT test every 1 to 3 years, CT colonography every 5 years, a flexible sigmoidoscopy every 5 years, a combination of the two, or colonoscopy. In general, things that the US Preventive Services Task Force gives a grade A or B recommendations are generally covered by Medicare, and most of the payers tend to follow Medicare. So very rapidly, this is covered by all major payers in the US. Now, the benefits of earlier age at screening need to be weighed very carefully against the harms. The benefits might be that we could reduce incidence in this younger age group with this rising incidence, and also in the process, boost screening in the 50 to 55-year-old, where screening rates tend to be lower. That needs to be balanced against the harms of screening, particularly when we think of colonoscopy being an invasive test. Do we have enough access? Do we have enough capacity? Do we have enough resources to screen individuals and bring them in? And we don't want to worsen disparities, meaning the people at the front of the line shouldn't be the ones that have good healthcare, good access, and crowd out the capacity for people that truly could benefit from screening. So those are some of the things to weigh and balance against each other. Now, let's look at the benefits versus harms from the modeling studies. So again, going back to the US Preventive Services Task Force document, they did perform modeling study. And the modeling studies suggest that the benefit of screening at age 45 compared to 50 is that we would avert an additional 3 cases of colorectal cancer per 1,000 individuals screened. And you can see, regardless of which screening modality is used, that number is between 2 and 3. Now, what are the harms of screening? In screening at age 45 compared to age 50 will also cause harms in about 0.2 to 2 per 1,000 individuals screened. So again, while we're producing benefits, we're also accruing harms. And these two need to be weighed closely. Particularly if a colonoscopy only strategy is used, the harms are not trivial. 2 per 1,000 individuals screened could potentially be harmed. So how do we balance the two? The other thing to think about in this context is, what about the burden of screening on our healthcare system? So by starting screening at age 45 compared to age 50, in the red box, you see how many additional colonoscopies we would need to perform for 1,000 individuals screened. And that number is not trivial, particularly with a colonoscopy-only strategy. And there's other tests that would result as downstream sequelae of that screening cascade. So that number is pretty large. And the question is, do we have healthcare systems that can absorb this kind of an increased demand? And that, again, is yet to be determined. If we look at the US overall, the screening rates are not consistent, and it varies very widely by geography. And you can see states in the Northeast or the Northwest tend to do better than states in the South and Southwest. Overall, screening rates are 64% if you were to average this entire checkerboard. And screening rates vary by race. Whites have the highest screening rates, followed by African Americans and Asians a bit lower. And as we mentioned, screening rates vary by geography. In New York, screening rates are as high as 72% in communities, whereas down in Texas, particularly South Texas, screening rates are much, much lower, 17 to 37%. So we need to first be improving screening rates in 50 and older and kind of make all the screening rates more uniform. But then by changing these guidelines, we've unleashed a storm of another 21 million adults in the US that are between the ages of 45 to 49 that are suddenly screen eligible. So how do we balance screening this increased load and doing it in a very equitable and organized fashion? And those are some of our challenges. Next, I'm going to pivot to family history. This is something that comes up very often with patients and providers. And here's what the guidelines recommend. So with family history, it's important to ask, was it a first-degree relative or not? And first-degree relatives are only parents, siblings, or children, and that's it. And then the next thing to ask is, was the cancer or advanced adenoma in that first-degree relative occur when they were younger or older than age 60? If there's a family history of one first-degree relative who was younger than 60 at the time of diagnosis, or more than 2 first-degree relatives any age with either cancer or advanced adenoma, the only recommended modality for screening is colonoscopy, starting at age 40 and done every 5 years. What we get more often is one first-degree relative that was older than 60 at the time of their diagnosis. And in those scenarios, the recommendations are to start screening at age 40, but use any modality, and then follow average risk intervals. So for instance, if a colonoscopy is done at age 40 and that's normal, the next one in interval would be 10 years. One second-degree relative at any age, which is another common history we get, somebody having a grandparent with a colorectal cancer, well, that essentially should portend no increased risk, and screening recommendations are the same as for average risk individuals, starting at 45 and then going every 10 years in the case of a colonoscopy. So we recommend obtaining a clear documentation of the histology of the adenoma or polyp in the first degree, because we get a lot of patients reporting that, say, their sibling or their parent had a polyp. And that alone is not sufficient. If we can't get that histology, we recommend assuming it wasn't advanced, only because it's so common to have non-advanced adenomas. And remember, benefits of earlier screening are highest when the individual, your patient, is younger than 50. After age 60, even with a family history, it's unlikely to confer an increased colon cancer risk. The other thing we addressed in our guideline was quality indicators for colonoscopy. So the idea is that a high quality exam is associated with a lower risk of post-colonoscopy colorectal cancer, and that's truly what makes colonoscopy effective. Adenoma detection rate, or ADR, is a validated quality indicator and one that we need to measure and track. How it's defined is it's a provider level variable, and it's the number of screening colonoscopies where one or more adenoma is found, divided by the total number of screening colonoscopies performed by that provider in a given time period. And the benchmark that's been set is 25%. Again, the aspirational goal is much higher than that, but at below 25% is where we start worrying that there might be quality issues and there's room for improvement. So this begs the two pressing questions. One is, as we lower the screening age, what can we expect in terms of prevalence of neoplasia and adenoma detection for endoscopists in this younger age group? So let's look at some data to inform these two questions. What we do know is, as we said before, the risk of adenomas and cancers increases with age, and that ADR is a validated quality indicator. What we don't know is what is the prevalence of adenoma in an asymptomatic younger individual, because we've never screened them before, and what impact lowering the screening age will have on the endoscopist's ADR. So this has been looked at by different studies. This is one of the first studies. It's the New Hampshire Colonoscopy Registry, and they looked at data over a 5-year period. They didn't have a purely screening group in the 45 to 49. So what they took was individuals coming for a diagnostic colonoscopy, indications being abdominal pain, constipation, or some non-high-risk indications. And they compared the findings on colonoscopy in this younger group to individuals 50 to 54 and 55 to 59. They found very similar rates of advanced adenomas and colon cancers in the younger group, suggesting we may not see any difference. So we've looked at this in multiple endoscopy centers in a community practice with over 223 average risk colonoscopies, with 99 endoscopists over a 5-year period. And we found that the adenoma detection rate in this younger group is several percentage points lower than ADR in 50 to 54-year-olds, and about 5 to 10 percentage points lower than 50 to 75-year-old screening population. Particularly in women, this difference was quite marked, with younger women having much lower adenoma detection rate. So we actually modeled this as having an effect on the endoscopist's ADR. So depending on the proportion of an endoscopist screening colonoscopy being that younger group, this is the change in their ADR they can expect. So if 5% of their screening colonoscopy population is this younger group, there may not be any change in the ADR, but as that proportion increases, you see a small drop in the ADR. However, it stays above that minimum threshold of 25%. So we can expect a lowering in the ADR, but it should still stay above the benchmark. And then we looked at the same question in GI Quick Registry, which is a national database of colonoscopies from across the US. We looked at over 2 million exams by 814 endoscopists from community and academic practices across the US. And again, you see that the ADR is several percentage points lower in the 45 to 49-year-olds compared to 50 to 54, and about 8 percentage points lower than 50 to 75-year-olds for screening. So that kind of tells us that we may see a small drop in our ADR, but it stays above the minimum threshold. All right. In the last few minutes, I'm going to turn to what the future might hold for the field of colorectal cancer screening And this is certainly an area we're very excited about. So there are very many blood-based tests under development. And the idea of these blood-based tests is we used to be able to only detect cancers at a very late stage, by the time there's enough tumor shed to be able to be detectable in the blood. However, newer technology allows us to detect cell-free DNA, looking at proteomics and metabolomic signatures, which allow us to start picking up cell-free DNA and tumor signal much earlier in the colon cancer pathogenesis. On top of that, we now have AI and machine learning tools. So these algorithms are very smart, and they get smarter over time once they get trained to understand patterns between normals and cancers. So that, along with several very powerful new platforms, has really made the field of blood-based cancer extremely important, and something that we can expect to see in the next few years. There are many ongoing studies with blood-based tests, and in the next few years, we expect to see the final results of a lot of these very large-scale trials. So this field will change very rapidly. And then the question is, how will blood-based tests fit in our current paradigm of colon cancer screening? So with a lot of interest from Medicare has truly set the bar of what they would consider for national coverage in terms of a blood-based test. And their remarks are that if it meets 4 criteria, they would consider it for approval. 1, the sensitivity for detection of colorectal cancer has to be at least 74%. The specificity for colon cancer detection has to be 90% or higher. The test needs to be FDA approved, and it needs to be guideline endorsed. And if a blood-based test meets these 4 criteria, it would be considered for national coverage. So now there's the bar's been set, and there's a need to meet and exceed these thresholds to get blood-based tests approved and in the market. So, and there's a lot of important research going on in this arena. There is one current blood-based test available. It's called the septin-9 or methylated septin-9. And right now, it's an option for patients not willing to undergo stool-based test or colonoscopy for colorectal cancer screening. The reason the test is not recommended first line is because the initial test had a very low sensitivity, much lower than that 74% bar. However, with increased iterations of the test, recent studies seem to suggest that the sensitivity can be as high as 74%, specificity 87%. So you can see it's starting to get very close to that threshold set by CMS. So more to come on that, but again, this is a very exciting field. And on that note, I refer you to this recent review on the topic, where we've summarized just a few of the stool and blood-based tests that have either completed their recruitment or are expected to be completed very shortly by the end of this year. And you can see there's many tests in this space, and it gives you a little bit of information of the technology of the tests and the expected completion. One of these tests by Grail is actually currently available as a lab-developed test in the US. It's currently not covered by insurance. It's an out-of-pocket expense, but nevertheless, it is available, and more data will be forthcoming on these tests. So it's an exciting field to watch, and there's much more to come. So in summary, there's a rising trend of advanced neoplasia and colorectal cancer in 45 to 49-year-olds. The prevalence rate of neoplasia in this 45 to 49-year-old group seems either very similar to 50 to 54, with maybe an absolute reduction of 0 to 5%, and then maybe lower when you look at older individuals, 55 and older, or 50 to 75. The ADRs in 45 to 49-year-olds are lower than for 50 to 55, and certainly lower than 50 to 75. And the absolute reduction is somewhere between 3 to 7%. And with these 45 to 49-year-olds now added to our screening pool, we now need to think about expanded colon cancer screening approaches. And truly, with availability of so many screening options, the emphasis is truly going to be on adherence, meaning which is the test that patients are most willing to undergo. Because as we've all heard, the best test is the one that the patient is willing to complete. So if we can find out what test may work for which patient population, offer them that test and have it completed, that's truly the goal of colon cancer screening. And there's some promising blood-based markers for colorectal cancer that are under development, and we expect to see more on these tests in the next 1 or 2 years. So I would say the story is not over yet. In fact, it almost seems like we're at chapter 1 of this exciting new area or era of multiple test options, including for the first time blood-based tests, which have the potential to be very disruptive and change the paradigm of screening. Colonoscopy will still be an important modality, and if not for screening, then it might be that step 2, that after this blood or stool test, it's the test that needs to be done for that individual. So that will keep demand of colonoscopy pretty high, but we'll be able to use perhaps our resources a bit better, and at the end of the day, get patients to adhere, which is truly our goal. So with that, I'll stop and take any questions, and I'm excited to engage in a discussion. Thank you so much.
Thank you so much, Dr. Shaukat, for this amazing presentation. I truly learned a lot on the prevalence of colorectal cancers and the latest updates in all these screening methods. It was truly interesting for me because I didn't know all of these existed so in depth about all of this. Really a great presentation. Thank you so much for this.
You're most welcome. I'm so glad.
So now I'm going to be passing the mic back to our moderator, Gayatri, for more on these discussions as well.
Thank you so much, Dr. Shaukat. I'm so excited to be speaking to you, and thank you so much for that amazing, insightful presentation. So to all our attendees, thank you so much for coming, and welcome to Discussions with Global Leaders. I'm Gayatri Menon, and we're excited to be speaking with Dr. Aasma Shaukat, Director of GI Outcomes Research at NYU Langone Health. We have received a lot of questions, Doctor, and we'll do our best to get through all of them in the time that we have with you. For the first question, I'm going to be passing the mic back to Madhuri.
Thank you so much. So my first question actually was, can fecal immunochemical testing rule out colorectal cancer in patients with high-risk symptoms who would require definite investigation?
Yeah, that's a great question. It comes up very often. The fecal immunochemical test, or FIT, is truly a test that's meant for average risk colon cancer screening. Average risk are individuals without any high-risk family history, like the ones we reviewed, or any symptoms, or any other high-risk features that increase their risk of having colorectal cancer. So that's really important, is first to offer it to the right patient population, which is average risk. And then in that population, the test is, according to studies, as sensitive as for colon cancer. It has a specificity of 90%, so which is extremely high, and a sensitivity of about 74%. So that's what we can expect from the test. Of course, it needs to be done every year because the sensitivity of a one-time test isn't great, which is why it needs to be done every year. But adhering to multiple rounds does seem to decrease the risk of colorectal cancer incidence and decrease the risk of dying from colorectal cancer. It's a very effective test. For individuals with either symptoms or family history or other high-risk features, they should get a prompt evaluation regardless of age, and most times that evaluation is usually a colonoscopy.
Thank you so much, Doctor, for this amazing explanation. I'm going to be passing the mic back to Gayatri for the next question.
Thank you so much, doctor. So my question is, patients that are treated for colorectal cancer should have carcinoembryonic antigen levels that should be monitored every 3 months. But unfortunately, an increase of CEA concentration is only sometimes observed during the first stage of CRC. So I was wondering what other biomarkers can we consider for the advanced stages of colorectal cancer?
Yeah, great question. We'd love to have a biomarker that essentially tells us about the risk of, for instance, a metachronous colorectal cancer. And CEA is one of them, but as we know that it tends to be more specific, but not as sensitive. So at the moment, we don't have great biomarkers, but that's one of the things that these blood-based tests are going to do is develop biomarkers, particularly in those individuals that have had, say, previous neoplasia, and we're monitoring them along with, say, CT scans or repeat colonoscopies to look for signs of early cancer. At the moment, we recommend colonoscopy at 1 year after their colon cancer diagnosis and resection, then at 3 years, and then every 5 years after that. In addition, CEA and CAT scan are the additional things that we like to do. So none of these is individually sensitive enough, but we're hoping that, with all these modalities combined, we'll be able to catch them. And then truly, I think there's room for blood-based tests to help us in this domain and come up with a more sensitive test that perhaps, could replace a lot of these modalities.
For that amazing answer. For the next question, I'm going to be passing the mic over to Billy.
Thank you, doctor. Thank you for being here tonight. Learned a lot tonight. So I wanted to ask you a quick question. Just basically, can you comment on some of the inequities that you see within your practice, sort of in terms of like access to care, and what are some ways to best address them?
Yeah, that's such an important question for the US, and it's one that every healthcare system has been struggling with. The National Colon Cancer Roundtable meets very often, and these are the kinds of questions they want to answer and address. We did address this in our guideline, and the way we framed it is one, pointing out that there are inequities. There's a lot of disparities in colon cancer screening rates. I showed you some of the data, but you don't even have to go across states to notice that. So where I practice in New York City, there's variation right there between, say, Manhattan and Brooklyn and some of the other neighborhoods in screening rates, colon cancer incidence, and death from colon cancer. So how do we improve health equity? How do we equalize the field and make everybody undergo screening and create access? And so that's a multi-pronged approach. Some of the limitations, of course, are limitations of our healthcare systems. As we know, individuals that don't have insurance and then don't have access tend to have lower screening rates. They also tend to not see providers and get recommendations to undergo colon cancer screening. The ways to mitigate that is having an organized program. And we discussed this in our guideline document, is that every healthcare system or provider should think about having some organized approaches. And there's some really novel EHR-based solutions where we shouldn't just wait for patients to come see us in clinic to discuss screening, but we should be reaching out to patients. Kaiser Permanente has done this model very successfully. And there's no reason why every healthcare system can't. So we can pull a list of everybody in our healthcare system that's, say, between ages of 45 to 75 and hasn't been screened. And then we should be doing a concerted effort and reaching out to them, approaches known as proactive outreach. There's great evidence that those approaches work. And then perhaps mailing them a fit, sending mobile phlebotomy to their home, offering them financial incentives or rides or anything that overcomes some of the barriers to get them to undergo screening. So that would be step one. And for individuals that aren't even plugged in a healthcare system, we need to think even broader. What can we do, say, at the population level? And these are things that departments of health and the states are taking on, which is providing coverage for these individuals to undergo screening. Also important, we can't just have one size fits all. And if the population, for instance, is non-English speaking or responds to, say, community engagement, then we need to be doing some of those approaches in order to reach them. So it's a multifaceted approach, and it truly needs to be tailored to the population that we're trying to screen, and we need to be screening every population. So that's a long answer, to a very complex question.
Thank you so much, Doctor. Definitely improving and increasing global access to these cancer screenings is an issue that must be addressed. Thank you so much for that amazing answer. For the next question, I'll be passing the mic to Aasma.
Hello, Doctor. I have a question same as on access, but I wanted to say, is there any technology or any technology advances that have been forced in colorectal cancer screening? But what do you think advancing technology can help in this aspects of diagnosing colorectal cancer?
Yeah, so what technologies can help us in the diagnosis of colorectal cancer? There's some very exciting technology that exists, and I would classify it in several categories. One is identifying the patients at risk. And there are now, very sophisticated electronic health record tools that essentially can target or look for, through millions of data points, the patients that are most likely at risk, patients with symptoms, those with family history, those high risk for other reasons because they have other health conditions. So one is identification using sophisticated EHR tools or these AI smart solutions. The second thing is offering them screening tests that are novel and easy to do. So blood-based tests are ones we talked about, but there's other emerging technology. There's PillCam, a capsule with a camera that the patients can swallow, can take pictures of the colon, again, tell us if there's a polyp and if a colonoscopy needs to be done, or are they considered screened? There's also an X-ray based capsule, an MRI based capsule that's under study, and some other newer novel technologies being developed. So that itself, I think, will have a huge implication on changing the field. And then there's advances in stool-based tests, as we've seen. So from FIT, there's been the FIT DNA test, and now there's a second generation of FIT. So I think stool tests will get, more sensitive and specific, not just for cancers, but for advanced adenomas. I think there's a lot of great technology on the horizon. And then it's incumbent upon us to make sure that we test it and understand the science and make sure we recommend it to the right patient population, and then make it accessible, whether it's cost, whether it's availability, whether it's provider recommendation, because all those things go hand in hand in terms of kind of getting the patient to that final step of undergoing screening.
Thank you so much, Doctor, for that very insightful answer. For the next question, I'll be passing the mic back to Madhuri.
Thank you, Doctor, for the really amazing explanation. So another question I kind of had was, in females, we can see an anti-tumorigenic properties with estrogen and progesterone levels against colorectal cancer. But we know very little about it for males. What are your thoughts about that?
Yeah, I'm so glad you asked that. So when you mentioned our New England Journal paper, when we did that study, I thought one of the most novel things we found were differences by sex, right? Men and women had very different risks of cancer at different ages. And, I think I was more enthusiastic about it than anybody else. So yes, there are differences in the risk for men and women by age. So women, compared to men, have a lower risk of advanced adenomas and cancers at younger ages. So for instance, a 60-year-old woman's risk is about that of a 50-year-old male. So it lags by about 10 years for women compared to men. And the reason for that is largely thought to be the protective effect of estrogen, particularly leading up to, say, almost age 50. And then also women tend to have healthier lifestyles, just tend to have lower risk factor profiles, lower smoking, lower BMIs, and lower exposure to other carcinogens. But overall, because women have slightly longer life expectancies than men, the lifetime risk catches up. So the implication that has is, if we were to really use that and tailor screening, one, we would use age and sex in our risk stratification tools. And second, what it might look like is we might start screening women maybe a little bit later, but go longer. And men, we could start earlier, but then because at a certain point, it doesn't benefit them to continue to go screening, maybe cut them off at 75. The reason that's a hard approach is because, then it gets very difficult to follow guidelines, and you want them also to be simple, a universal message that everybody can follow. So there's that trade-off. You can be very tailored and risk specific, and you could throw in other information too in that equation. And people are trying to do that, such as aspirin use, smoking, BMI, healthy lifestyle, diet, activity, and even some genetic profiles. But then it starts getting, very complex, even though we start tailoring it better. So I think there's still movement in that direction, and we might see certain risk calculators pop up as a guidance tool for clinicians, but also the simple message of getting everybody in, say at 45, then it doesn't pose barriers in calculating the risk scores is also a good message. So I think that's the trade-off between the two approaches.
Thank you, Doctor, for that really amazing explanation.
Thank you so much, Doctor. I'll be asking the next question. So, Doctor, I had a query about colorectal cancer. Considering it is known for its wide temporal and spatial intratumor heterogeneity, invasive solid biopsies might pose a risk. So, I was wondering, how optimistic are you about the use of liquid biopsies instead?
Yeah, another very important area. We know colorectal cancers are extremely heterogeneous, and there isn't a single molecular profile that one can pin them down. We think the vast majority of cancers pass through the adenoma carcinoma sequence, which is that Wnt signaling pathway with APC mutation, followed by KRAS. But we also know that a small number go through the have kind of methylated tumor marker with epigenetic silencing of the tumor suppressor genes, and they tend to be CIMP high. And then there's the microsatellite instability tumor phenotype also. And these types are not just important in terms of when the cancer happens and how rapidly it grows, but it also has implications on, for instance, prognosis and response to treatment, and also long-term risk of recurrence or metachronous cancer. So our molecular tools are only expanding in this domain. And for instance, now we can do chemotherapy that's tailored to, for instance, EGFR or other tumor markers. So very rapidly we'll have some of these panels even for cancer detection. But that is a challenge for these blood-based tests, which is why they don't focus on just one particular molecular phenotype. What they try to do is perhaps combine all these signatures. And then, so you can't really tell exactly what is causing that positive test, but it's a signal, which is a composite of all these tumor markers plus proteomics and metabolomic signatures put together. So that all you can say is, look, it looks different from normal. We can't exactly tell you which exact mutations might be present, but that's enough to say the test is abnormal and this person should undergo colonoscopy looking for cancer. So I think that's the broad encompassing approach these tests are taking, is to take all that heterogeneous tumor tissue signal and put it all together in one signature, because tumors tend to be so heterogeneous.
Thank you so much, Doctor, for that amazing answer. I really learned a lot. Doctor, one more question I wanted to ask you is that I would love to hear your thoughts about pediatric bowel preparations for colonoscopy, considering there are no national standards set for this procedures. I would really love to hear your thoughts on this.
Right. So you also point out a very important aspect is the bowel prep. So the most difficult part of colonoscopy is the bowel prep, and that's true for pediatric patients as well as adults. I obviously mostly see adults, and my colleagues see mostly pediatric patients, but we do see a lot of adolescent patients, particularly those that are high risk for colorectal cancer, and maybe at risk for, say, an underlying genetic syndrome. And PrEP is truly one of the biggest challenges we have. The most well-tested PrEP solution is the polyethylene glycol. And it is by far has the largest safety profile. It has a great cleansing profile. And so our mainstay of PrEP is trying to get that, go lightly solution down. It's a gallon for adults, might be less volume for children, or depending on their age or their body size. And we have different tips and tools to make it more palatable. So for instance, we recommend putting in the fridge and putting it on ice, putting in some, iced tea or some other flavor like Crystallite in it to make it more palatable. Sipping it with a straw, taking half of it the night before and half of it the morning off instead of trying to chug it all at once. Anything we can do to kind of make it more palatable, because again, the colonoscopy is only as good as the PrEP. And actually, that's one of the quality indicators. The PrEP should be adequate in 85% of all colonoscopies and 90% of screening colonoscopies. So it truly behooves us to track our PrEP quality rates. And then if they're below these benchmarks, figure out what we need to do to fix them. Other things people have tried, Miralax is a very popular over-the-counter agent in the US. So that's used pretty extensively with Gatorade. There's also smaller preparations like magnesium citrate that tend to be lower volume. Again, caution for patients with kidney disease, but for younger, healthier patients, those are great options. So the thing to do is to see what's available. It needs to be affordable, accessible, and something that is palatable for the patients. And then coming up with tips of how they can some hacks of how they can make it easy to tolerate so that the colonoscopy PrEP is, complete and adequate. And now there's newer tools coming out, this special flushing hose that can be attached to a colonoscope. And even if the PrEP is suboptimal, it can make the difference in converting it to optimal PrEP by kind of aggressively lavaging and suctioning debris so that, we don't have to reschedule the patient, cancel them, bring them back, because a lot of patients just don't come back. And it's a huge burden on the patient and the healthcare system. So anything we can do to avoid that is really important.
Thank you so much, Doctor. Again, such a wonderful answer. Really, I'm learning a lot listening to you. For the next question, I'll be passing the mic over to Aasma.
Thanks for a wonderful explanation on the ball preparation, ma'am. I have a question on how do you think precision medicine would be changing the therapeutic outcomes of colorectal cancer in near future? How do you envision precision medicine in colorectal cancer and its diagnosis or therapeutics?
Yeah, that's such an important area and one that we're very excited and seeing progress. So there's something that we touched upon. So for instance, precision medicine or AI tools, one, they can identify people through the electronic record. So you don't have to wait for the patient to tell you, hey, I'm high risk or I'm having symptoms. But based on what's available already, these algorithms can actually identify or flag people that are at increased risk, whether they've given a family history, whether they're reporting symptoms, whether they have some other condition like PSC or inflammatory bowel disease that puts them at increased risk. So they get flagged, and there's a way to track these. And then the healthcare system then has to then reach out to them and say, our system has flagged you as somebody that's at high risk. We need you to come, talk to a provider. And then the recommendation is to undergo screening. So one area is taking all this data and using kind of precision medicine tools to identify individuals at high risk. The second thing is kind of doing population-based outreach. So we can leverage a lot of these precision medicine tools to tailor screening risk. Individuals, like we mentioned, the EHR has information on BMI, smoking, aspirin use, So there's no reason why we can't combine that in a risk score and say, you're identified as somebody as having high risk, you should undergo colonoscopy, or the other direction, you're somebody identified as being low risk at colon cancer this year. So we recommend a stool test or a blood-based test, and then in a year, we'll repeat it again to see how that profile has changed. So that is some of the tailoring that can happen, and precision medicine allows us to do that. And then same for cancer diagnosis or, prognosis. So I think that field is just going to continue to improve. And patients are very excited about that because that can look at patterns beyond what us humans can comprehend or pick up. And then there's also economy of scale. So instead of just looking at my panel of 100 patients, we can look across hundreds and thousands of patients across the healthcare system. So there's a lot of efficiency and economy of scale in that arena. So I would say that those tools are available. Some EHRs have started using them, and I think I see them proliferating a lot in the next 5 years or so.
Thank you so much, Doctor. Wonderful answer. Now, for the last question of the day, I'll be passing the mic over to Pradyusha.
Thank you, Gayatri. Thank you, Dr. Shaukat, for that amazing PowerPoint and for that presentation, your lecture. So my question to you is, for our junior attendees just getting into research in medicine, what inspired you to pursue this field? And also a follow-up, has it been everything that you had initially anticipated? Thank you.
What a great question. And what a great question to end on. So I did a master's in public health because I was always interested in problems at the public health level that we can address and solve. And very early on, the idea of colon cancer screening really intrigued me. I felt like it was one area where we knew enough to really take it to the next level. And there was a disconnect between what we knew and what was actually being carried out. And it's, again, one of those kind of preventable, beatable cancers. So there's some immediate, effects to be seen. So that truly got me started on this field. And I kind of pursued projects and ideas and a lot of my career in areas or institutions to be able to pursue that. So my advice to junior colleagues and trainees is, if you have a passion about a field, absolutely develop it, and to the point where you're ready to commit to it. And if you are, try to pick something that you're enthusiastic about that really resonates with you, whether it's a personal connection or something that you just feel gravitating towards, because the enthusiasm and energy is very important, right? Because this is a lifelong thing. It's not a sprint, it's a marathon. So you can only do things that you truly care about long term. So keep that in mind. So find your North Star and follow it, and see what truly resonates with you, and don't be afraid to pursue it, and don't be afraid to set lofty goals, and be persistent, and you'd be surprised that it's always achievable to pursue a goal. So never give up and be persistent.
Thank you so much, Doctor, for that very, very inspiring answer. I think we can all agree that it's been a very enriching session for all of us today. Thank you so much for joining us. And a huge thank you to all of our speakers, to our speaker for an amazing session. Thank you for all the great questions, and to all of our attendees.